Okay, hello everyone. This is Brother Wolf, and this is HS 375. And tonight's group will be presenting to us on acute care hospitals. And I will turn it over to them to start whenever they're ready.
Okay, awesome. So we'll go to the next slide. So just kind of a basic hospital definition. According to the Merriam-Webster Dictionary, the definition of hospital is a charitable institution for the needy, aged, infirm, or young, and an institution where the sick or injured are given medical or surgical care. So pretty self-explanatory. So we'll start out by talking about kind of the religious roots of medical facilities. Technically speaking, medical facilities began way back in Egypt, in Egyptian time, but we're kind of going to start with the beginning of Christianity and move forward. So during the early years of Christianity, the Christian churches really started to push people to help the sick, the homeless, the hungry, the poor. And so as that kind of mentality moved forward, wards were created where people could go and get help for these things. By the 18th century, the idea that people could be cured from diseases inspired growth of medical schools, particularly in Germany and Italy. So as more cures came about and people were able to find new cures for things, hospitals started to grow, teaching hospitals started to grow, and hospitals became less religious and more medical and scientific. In 1751, Benjamin Franklin helped to start the first hospital in the United States, which was the Pennsylvania Hospital. Next slide. So there's kind of two different types of hospitals. You have your not-for-profit and your for-profit. Not-for-profit organizations do not produce a profit for its shareholders. So instead of giving their revenues to those that own the company, they use all their proceeds to help fulfill the mission statement of the organization. They are tax exempt, and a lot of their contributions are tax exempt contributions. Traditionally, because Christian churches were running all of the medical organizations, all medical organizations were not for profit. It was all volunteer. And so we can go to the next slide and talk about for-profit organizations. So unlike not-for-profit, for-profit organizations want to increase their shareholders' equity. And so when people buy stock and buy into the company, the goal of the company is to return that money to those shareholders. Kind of the growth of for-profit began after World War II. More people started utilizing hospitals, so the demand for hospitals grew also. And then after Medicaid and Medicare were established in 1965, more people were able to pay for care, and so both nonprofit and for-profit organizations grew. After some provisions in the Medicare bill, for-profit organizations expanded substantially during the 80s. So now there are approximately 1,053 for-profit hospitals in the United States.
So the different hospital demographics and type of facilities are, like she said, there's the public hospitals that are funded by local, state, and federal funds. Those are the not-for-profit. And you've got your private hospitals that are privately owned and they're for-profit. There's community hospitals, which are all non-federal, short-term, general, and other specialty hospitals. And non-community hospitals are federal government hospitals, non-federal psychiatric hospitals, non-federal long-term care hospitals, prison hospitals, and college infirmaries. And then we talked about the for-profit and not-for-profit. What I found when I researched bed size is that the amount of hospital beds vary from hospital to hospital, and the hospital needs to plan to get the patient in the most appropriate bed in a timely fashion rather than trying to meet target occupancy levels. And the main difference between the rural and urban hospitals is the rural hospitals tend to be much smaller than urban hospitals and don't always have a doctor on site 24/7. The critical access hospitals, I found that it can be beneficial for a small hospital in a rural area that is more than 35 miles from another hospital to become a critical access hospital. They're eligible for a grant from the Medicare Rural Hospital Flexibility Program, which was set up in 1997 as an initiative to help strengthen the rural healthcare infrastructure. And the disproportionate share hospitals serve a large volume of low-income patients, and they receive a payment from the Center of Medicaid and Medicare, and it helps them with the rural hospitals. Or excuse me, not the rural hospitals, the low income. If they have a lot more low income patients, they need to help. They need that to help take care of their to pay for the services. And here's some fun facts on the U.S. hospitals from the American Hospital Association. I won't read through each of them, all of them, but it tells you how many of the different hospitals and how many staff beds and admissions and the total expenses for all the hospitals. I thought it was interesting numbers to look at. And the different advocacy and representation groups. The two main ones are the American Hospital Association, the AHA, and they're the ones that represent the not-for-profit hospitals and organizations. They were founded in 1898, and they include over 5,000 organizations and 42,000 individuals. And they're a source of education and information on healthcare issues and trends. They advocate for their members in national health policy development, legislature and regulatory debates, and judicial matters. The other one is the Federal Association of Hospitals, the FAH, for the for-profit hospitals and organizations. They were founded in 1966, and then they include over 1,000 investor-owned hospitals and health systems. They advocate for effective and sound policies at a federal level to ensure access to quality health care for all patients.
Just some statistics on hospitals. There are a total of 5,627 registered hospitals in the United States. Of those, there are 3,183 multi-hospital systems, which multi-hospital systems are the two or more hospitals owned or leased or managed by one central company or organization. And of those, there are also 1,619 hospitals in a network, which a network meaning integrated healthcare networks, hospitals, providers, insurance that all come together to provide services for patients. There are also more than 3,300 ambulatory surgery centers in the United States. So those are the outpatient surgery centers. And there are 4,926 community hospitals in the United States, which are the hospitals defined as short-term general hospitals, specialty hospitals for short stays, or acute care hospitals. The next slide.
So there are 4 different levels of acute care. The primary care is the most common it's a visit to your primary care provider for symptoms that are new to us or concerns that we have contracted a bacterial or viral disease, for example, a broken bone, cut, or rash. The secondary level of acute care is being seen by someone who has more expertise in whatever problem we are having. We're usually referred by a primary care provider, for example, to see a cardiologist who specializes in treating the heart and the pumping system. The tertiary level is once the patient is hospitalized and needs a higher level of specialty care. This level of care requires highly specialized equipment and expertise, for example, treating someone with severe burns or for neurosurgery and cardiac surgery. The last one, the quaternary level of care, is an advanced level of medicine that is highly specialized and not widely accessed. Since it's so specialized, not very many hospitals offer this care. For example, it's experimental medicine and some types of uncommon diagnostic or surgical procedures.
Okay, so hospital reimbursement. The main players in hospital reimbursement would be Medicare and Medicaid from government funding, and then also private insurers, and then the patients themselves. Look to my notes if you want more detailed description on each one of these, but I'm going to run through a few more specific aspects of hospital reimbursement. The first one is the inpatient prospective payment system, so that's within Medicare. And basically how this goes is every patient discharged is assigned a DRG, so that's associated with a certain weight that reflects amount of resources needed to serve each patient. So this is how they get the amount that each hospital will be paid. They take that weight and they multiply it by a dollar amount that's adjusted for the different area hospitals in. And then the Medicare DSH payment, this is the disproportionate share hospital. So basically this means that U.S. government funding to hospitals, or they compensate hospitals that have higher operating costs for treating a large portion of low-income patients. And then the Affordable Care Act has made a few big changes in hospital reimbursement. And a couple of specifics I have on there is the readmissions reduction program. So this means that Medicare can reduce payments to acute care hospitals that have an excess in readmissions. And so hopefully that inspires hospitals to improve the quality of their care so they have less readmissions. And then in the VBP program, this is based on how well hospitals perform, so they can adjust their payments based on how they compare to other hospitals and how that hospital compares to its own results from previous years. And the acquired condition reduction program, Medicare can reduce their payments to a hospital that falls within the worst performing quartile, so below 25%. And sometimes that can reduce their payments up to 99% of what their charges would be. Just really quick about Medicaid, hospitals receive either case-based payment, so per case they're paid back, or per diem, so it's like a set amount of dollars per day of inpatient stay, or individual fee for service. And then private insurers, it's either based on capitated amounts, pay per person, or pay per service. And these are fees that are negotiated between a hospital and each insurance carrier. Next slide.
Just a quick thing on private practice physicians. More middle career physicians and newly graduated physicians are moving towards being employed by hospitals instead of doing their own private practice. And just some reasons for that are debt from medical school. They're not wanting to be in more debt before they're able to pay off their school loans. Economic pressures, just movement of the economy and property value and just the different presidents and things like that. Overhead. Overhead's usually paid by the hospital or the system that the physician is working for. So if you don't have that hospital to pay for your overhead, there's a lot more money you're working out for that. Reimbursement and collections is all done by a hospital. They have a billing department that usually the physician doesn't even have to think about. Whereas in private practice, the physician is mainly the CFO of that, and so they're directly over the billing, and so they have a huge handle in that. Coverage for practice and call, whenever the physician wants to or needs to go out of town, usually in a bigger hospital system, there's somebody to take call for him or see his patients while he's out of town. And because there's so many more physicians, whereas in private practice, usually it's you, maybe a couple other physicians, but it's a lot harder than just handing everything over. And then another thing was retirement plans. Most major hospital systems have retirement plans in place, and private practice, you'd have to pay for your own or figure out your own way you want to pay for your retirement. And I found, going over the research and everything, the main reason physicians choose to be in private practice is because they can be their own boss. They have no administration over them. They are the administration. So that's a big thing. Next slide.
All right, so the government is a community of board members, executives, and thought leaders dedicated to advancing excellence. So they focus is on management oversight, financial management, and community response. So they basically make sure that everything is working good together. So I put a quote on here from a guy who was on a board for a long time by Don L. Arnwine. And he said, the wheel of effective governance has three spokes: behavior, structure, and expectations. If one of these spokes break down, the board will have a flat tire, and the faulty governance process can compromise the organization's ability to move forward. So basically, if you don't have a strong governance, then you can't move forward very well. Next slide.
Okay, so here's 6 legislative and regulatory initiatives that have made a difference in hospital management. And a lot of them probably sound familiar to most of us. So the first one is the Affordable Care Act. And like I said before, a lot more is explained in the notes under my slide. But this brings a lot of changes to healthcare constantly and continuously. So it was implemented in 2010. And its purpose was to lower the rate of the uninsured in America, expand coverage, increase quality and affordability of health insurance. And so that continues to make a lot of changes within hospital management. Next one was HIPAA. So that is the Health Insurance Portability and Accountability Act. This was legislation passed during 1996 during Clinton's administration. It was for data privacy and security to safeguard medical information. In my extra notes, it talks about the 5 different sections of HIPAA that contain. They're actually really interesting, so definitely look at those. Then CMS has certain pay-for-performance initiatives that have made a lot of changes in the way hospitals do quality improvement, and also physicians and physician groups. This pay-for-performance initiatives, they do demonstrations for hospital quality so that hospitals can evaluate and improve themselves also. The next one's called HITECH. So this was an act about health information technology, and it's done by the Department of Health and Human Services. And this establishes programs to improve healthcare quality, safety, and efficiency. And then it goes on, there's the Healthcare and Education Reconciliation Act. So this was actually a reconciliation bill that made changes to the Affordable Care Act, made more subsidies, penalties for not having coverage, changed payments, and then talked about student loans and then tax avoidance also. And the last one was called the Patient Perspectives of Care Survey. So that requires hospitals to be able to allow their patients to provide feedback on the care they receive. And then this measures patient satisfaction. So this is a way hospitals can collect data and compare it to each other. And it's also publicly reported and allows hospitals to improve their quality. Next slide. Okay, I can do this one. So this is basically just a graph showing the organization of the medical staff within a hospital. Next slide. And this is a board of directors, what a hospital management would look like. Everyone can just review that.
Okay, so I'm doing this last slide. Basically, these are different organizations that can help you in your professional career. A lot of them you do have to pay to be a member, but they have different chapters. You have access to different research topics. You have access to different job openings, so really useful information. So definitely check those out. Next slide. And those are our sources.
Excellent. Very well done. So let me just highlight some things. You guys hit all of the major points. And one of the things, and I noticed on one of the slides where it was giving a bunch of the numbers of the different kinds of hospitals, I wanted just to clarify for the class that this module, we're trying to focus on acute care hospitals, and I want to ask the group, think about it, and then when I finish talking, you might jump in. What is acute? Why acute care hospitals? And then we're going to differentiate a little later on in the course. There are other kinds of facilities called like a skilled nursing facility or a rehab hospital. And those hospitals, we're trying to reserve that kind of stuff for later in the course, and that this module is focusing on acute care hospitals. So you'll hear these different kinds, even though they all might be a hospital, right? Not all hospitals focus on the same things or treat the same things. So if I could ask the group, how would you guys define an acute care hospital? What does that term acute care mean?
Yeah, I think acute refers to short term. So they don't want people to be in there for a really long time. as opposed to like a skilled nursing facility where they anticipate that they'll be in there for a long time. And as we've seen, like with Obamacare or the Affordable Care Act, there are initiatives to get patients in and out as quickly as possible and not be readmitted. So they're anticipating them to be in there for a short period of time.
Exactly. So acute care, another way to think of acute care, and that's right, it's kind of a shorter term type of time frame. And it's really acute care, another way of saying it is it's medical care for the ill or the injured. And it's kind of that acute phase, right? So somebody might have a stroke and they get admitted to a hospital, and when they're admitted, maybe they're going through the ER. Initially, you're trying just to stabilize the patient. Number one, you want to make sure they don't have more strokes, or if they had a stroke and they're bleeding, you want to stop the bleeding. So you're taking care of some sort of acute or recent illness or injury. And then as you stabilize them from an acute standpoint, then you're going to do just what you guys said, which is you're going to try to discharge them from an acute care hospital, and maybe they'll go to a skilled nursing facility or a rehab hospital. So the patient had a stroke, and now they can't use their right arm and right leg as well as they used to. So now they're going to have rehab. That kind of facility would not be considered an acute care hospital. So just kind of think about those kind of differentiations in your own mind. The number of hospitals varies from year to year. I think you guys said, was it 6,200 or something? Go ahead.
5,600.
56. Yeah. Okay. Thank you. So, yeah, think around 5,600, 5,700 is kind of the general number. You don't have to memorize the exact number, but no, it's not 8,000. It's not 4,000. It's about 56, 5,700 is the number that you want to be thinking in your mind. The other thing is you mentioned Medicare, and so you mentioned the Centers for Medicare and Medicaid Services. That is CMS. A lot of people talk of CMS, and when they say CMS, they mean the Centers for Medicare and Medicaid Services. And Medicare is the part of that organization or that agency. And there's four there's four different parts of Medicare. If you're a hospital administrator, what parts of Medicare do you think are going to reimburse you as a hospital? So there's part A, B, C, and D.
Isn't it B?
So let's go through those. What does part B pay for? If you had to just say it in a few words.
Well, part B pays for the hospitals. Right?
Pays for doctor services.
It does. So part B pays for physician services and outpatient services. So hospitals' outpatient services can be reimbursed through part B. But what about their inpatient services?
That's part A.
That's part A, and that's only hospital inpatient. So physician inpatient service, because doctors see inpatients, right? Their professional payment for what they do is paid through part B, even if they're seeing inpatients. So part A is hospital inpatient reimbursement only. Part B, and I'm using general terms here, but for the intents and purposes of this class, we can use these general classifications. As you advance in your careers, you're going to find there's some nuances to all of this. But in general, Part A pays for hospital inpatient, Part B pays for physician and outpatient services. It could be hospital outpatient. And then what does Part C and D pay for? It's not really pertinent to hospitals, but let's just kind of complete the picture.
I look at Part C as a replacement plan. It's the...
Yeah.
And then Part D is the prescription drugs, right?
Exactly. Part D is prescription drug, and Part C is kind of, it's what they call supplemental insurance. It's kind of, it's Medicare Plus Choice. It's an HMO type of, it's managed care for Medicare. Otherwise, what is known as traditional Medicare is the Part A and Part B, and that's when patient gets procedure X done. Because it's procedure X, it gets reimbursed this much. Whereas Part C is trying to use the managed care model like HMOs and that type of thing, but in a Medicare environment. So those are the four major parts of Medicare. You mentioned, one of your slides mentioned the disproportionate share hospitals. And in the class material, there's a 1 or 2 page document that kind of gets into a lot of detail. And it's important to read that. But I think one important takeaway is you don't need to be memorizing the formula and how is it going to determine payment. But you should know that disproportionate share hospitals are generally those hospitals that they care for more than the national average of Medicare patients. So if you're a hospital and you're thinking, okay, hey, I might get some more reimbursement from Medicare, but you only treat under the national average of Medicare patients, you're probably not going to get a disproportionate share payment. So you're not going to be a disproportionate share hospital. Again, there are some nuances and there's some formulas and rules to figure that out, so there might be some exceptions, but I'm giving you a general rule type way to think about this. So just think of it that way. Disproportionate share hospitals, they care for more than the national average of Medicare patients. The other thing I wanted to mention was you talked about critical access hospitals. I believe you had a slide on that. There's typically a limit of the number of beds that you can have in those kind of hospitals. Did you guys come across that?
Was it 20 or 25? I'm trying to think.
Yeah, it's 25.
25.
So if you have 26, you're not going to be able to qualify as a critical access hospital. You guys talked, I'm just looking at my notes from your presentation, you talked about the AHA and the FAH. Let's talk a little bit more alphabet soup. I'm not going to give you all the answers here, but you should know some of these other groups and abbreviations. The ABMS, the HSCA. You guys talked about PPACA, the ASCA, the CASC, and when it comes to professionals, you'll hear terms like an RN, an LPN. You'll hear CRNA. You'll hear an MD or a DO or a DPM. Those are professional designations. Other societies, the AMA, you know of. In our world of healthcare administration, you'll come across organizations, and these tend to be hospital type of organizations, the HFMA and the ACHE. Those are all, I don't want to spend a lot of time going over that right here, but those are all types of groups and abbreviations you should know. The other thing, let's see, we went over that. Yes. So tell me, who licenses hospitals?
JCO's one of the licensors.
Okay, not quite, and I'll comment on what JCO does.
Surveyor, yeah.
Go ahead. I'm sorry, say that again?
No, I was just saying they're one of the surveyors that...
Yeah, what JCO doesn't give a license to a hospital. What do they give? It's a different word.
It's credentialing, isn't it?
Yeah, accreditation. So JCO, and it's not known as JCO anymore. It's known as Joint Commission. They're a private entity, right? They're not a government entity. They're a private entity that you pay as a hospital. You pay them, and they come in and tell you whether you're good or not, more or less. And they define good as meeting their standards. But they're not the ones who give a hospital a license. Any other guesses on who actually grants the hospital a license? You think Medicare is the one that does it? Let me hear you say yeah. What do you think? Medicare, yay or nay?
I don't think so. Is it the AHCA?
No. So each state will grants a hospital a license. Now, when they grant hospitals licenses, they use criteria. They generally don't use criteria that they have set up. Now, some states might do that. But in general, and for purposes of this class, most states use other criteria that have already been developed. Anyone know what that criteria might be? And it's not JCO, it's not Joint Commission.
Isn't it the Medicare laws?
Yeah, it's the CMS. They're called conditions of participation, abbreviated for short COPs.
Mm-hmm.
So conditions of participation. Now, those conditions of participation are required in order to meet Medicare eligibility, but you don't have to meet Medicare eligibility to get a state license. So the reason I'm kind of going through all this, and I'm glad somebody mentioned Joint Commission, is because we hear all these different things and we think they're all the same body or entity and that they're all responsible for regulating hospitals. And in a way, they all have that kind of effect, but they have different levels of authority. A Joint Commission is only if you invite them in and you want to pay them, and it's very expensive. But a lot of hospitals want to do that because they want to be recognized as meeting this high standard, and Joint Commission is kind of that gold standard. But there are other accrediting bodies. If you remember from HS 285, we talked about other accrediting bodies in that course. But licensure is a state thing, and it's just unique that the states happen to use CMS's, which is a national thing, CMS's conditions of participation when they're granting state licenses. Most states. So I just wanted to kind of point some of that stuff out. It can get kind of confusing. The other thing you guys talked about was a little bit about physicians and how a lot of them are joining these multi-practice or multi-hospital systems and things. And you also, one of your slides talked about the 4 levels of care, and primary care was the first one, right? Mm-hmm. Where is most, if you had to guess, where do you, and there might be 2 or 3 answers here, where do you think most primary care is provided? Like, what's the location?
The outpatient setting at the doctor's office?
Yeah, exactly. So it's usually done in doctor's offices. That's one of the primary places. And then for people who tend not to have a primary care doctor, where might they go?
Oh, the Instacare and...
Yeah, and Instacare is one system's name for it, but those are typically called urgent care centers, right? Or urgent care clinics. So physician offices, urgent care clinics, and then one more that is hospital-based.
Oh, the emergency room?
Yeah, unfortunately, I'm not saying it's the best place, but a lot of people will go to the emergency room to get their primary care. So if you're thinking about primary care and where it's being delivered, and again, there's many places where it's delivered. An OBGYN office, for example, will deliver primary care. Student health center. So there's all sorts of kind of nuanced answers, but in general, you have physicians' offices, you have urgent care clinics, and you have many times emergency rooms. And on the concept of emergency rooms, who do you usually see, excuse me, when you first walk into an emergency room? Where do you go?
To registration.
Yeah, and what do they do? There's usually a nurse, and there's a name for that kind of nurse.
Is it triage?
Yeah, triage nurse. What does that word mean, triage?
Don't they determine how urgent your problem is?
Yeah, so they kind of determine the level of acuity, right? Because, if you're coming into the emergency room and you have a cut on your arm, but, you're holding pressure on it and you're not going to die from it, and somebody else gets wheeled in right behind you and they're having a heart attack, you might have to wait. And that's appropriate, actually, right? Because they've been triaged, and the word triage has the word tri in it, T-R-I. So, or the prefix, I should say. And so triage comes from it means to separate into 3 acuity levels, okay? And that's something that typically will happen in the emergency room as well. Those are my main things that I wanted to highlight. You guys did a great job. I know this is a big topic. If you would be so kind as to post your slides in the group discussion board this week, or the student chat board, excuse me, and then I will post the link for this recording. The other thing that you should be doing after you post your slides is just monitor that discussion board from now until the end of the week. people may ask questions, they might not understand something. This is your opportunity as a group to kind of teach the rest of the class about acute care hospitals. Does that sound okay?
Mm-hmm. Sounds great.
Yeah.
Any last minute comments or questions before I let you go?
Nope.
I think that's it.
Okay, one other thing I should say is if you want to, you can send me an email privately and you can rank kind of the contributions of the rest of the group. If you feel everybody contributed equally, you can just say, hey, we all contributed equally, or don't send me anything, and then I'll assume that's what you think. If you feel like certain people, deserve more credit, and certain people it was hard to work with, and they just never answered, that kind of feedback is welcome as well, and I take that into consideration when I'm assigning the group grade. And that's not required for you to do, but it's an opportunity if you want it. Just email me privately.
Okay.
Okay. Thank you.
Excellent. Thanks for your work, and I appreciate your efforts. Have a good night.
Thanks. You too.
You too.